Welcome to The Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Graper Harper Cosmetic Surgery in Charlotte, North Carolina, The Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper and Dr. Robert Graper, also known as The Doc Dudes.
Well, welcome to another podcast episode of The Doc Dudes. We are Garrett Harper.
Bob Graper.
Linda Owens.
Isn't that great? Like just the three of us hanging out, chilling out. Today we are talking with the title of this podcast is The Nose Knows, Understanding Rhinoplasties. And so I'm excited because I don't do rhinoplasties, so I just get to ask questions today, and Dr. Graper and Linda have to answer all these questions. So I'm going to give them some really difficult questions to try and stump
Bring
them.
it.
No, I'm really not going to do that. But I think that, rhinoplasties are one of those things that they really kind of scare us in training about rhinoplasties and how kind of complex they are. And sure, there's a ton of different maneuvers. I remember we did a ton in training, the majority of which we would do for cleft lip and palate kids is where we got the majority of our training on just the dissection, right? But the anatomy is kind of neat because it's more structural than, say, a breast or—
It's got bone.
Yeah, it's got bones, it's got cartilage, it's got things that you can sew to. But there are a lot of level 2, level 3, level 5 moves that you can do with rhinoplasties. So we're going to talk about kind of what Dr. Graper's philosophy is. I think it's awesome because I can't imagine there's anybody in town who does any more than he does. I certainly don't think anybody does anything prettier. So that's great. And then we've got, Linda Owens, who is an aesthetic injector here at Graper Harper Cosmetic Surgery. But that's the least of what she does. I mean, she's an educator and trainer for Allergan Medical Institute, who are the manufacturers of Botox and a lot of fillers. I mean, they hold the market share, and they go around the country and they kind of identify who the best of the best are. And she's one of them. And that's not like Dr. Graper and I coming up with that and
that is our opinion as well.
That is our opinion as well. But it's also theirs. I mean, they have asked her to go train people across the country so that they can get better with their products and feel more comfortable with them. And they feel like she's so great that she's the one that they fly all around. She's got back from California. What's up, California girl?
I know, that was wonderful.
I know.
There's a new program called Accelerate. Mm-hmm. It's not brand new. Mm-hmm. It's been out for about 2 years, and Allergan promotes it and is responsible for it. And it's a program that I had a privilege this year of being involved in.
That's awesome.
So there are 50 attendees, and it's for new injectors with 0 to 3 years experience. And there were 5 of us who were leading the program. You had to
perform.
Well, you
had to get up there and actually do it. You're not just like talking theory. You're actually showing these people how to do it.
We were talking. We had different stations for patient, for the
cadavers,
attendees.
did you do?
It wasn't cadavers, but different stations letting them see the rheology of the fillers.
Yeah.
And then we broke out into sessions, and each of the 50 attendees could bring their own model to inject. And so we were there training them hands-on, guiding them, directing them. And it just gives these new injectors a boost of confidence and helps them to accelerate their confidence in their business.
And nobody better equipped, better suited to train the next generation of nurse injectors than you. And I say that with love in my heart and
respect.
Well, y'all are sweet. I appreciate that. I do count it as just a great honor to have been invited, and
absolutely,
and to be able to do both, to work here and to treat beautiful faces, and to also be able to educate on it. It's a passion that I've got for both.
It's awesome. I love that. So we're going to talk about rhinoplasties. So first of all, define rhinoplasties. And what I say by that, I'm going to try and kind of lead this because that's a nebulous thing to say. So talk about the two different surgical approaches as far as open versus closed rhinoplasty, what that means, what the person listening may read somewhere or watch somebody on a Instagram reel that says, I only do closed rhinoplasties. It's the best, no scar. But like, what are kind of the pros and cons of an open versus a closed rhinoplasty? Which do you prefer and why? I mean, I know the answer to this, but let our audience know.
So, as you know, I trained in Dallas, and at Dallas at the time had a guy named Jack Gunter, another guy named John Tebbets, another guy named Steve Bird, and they were really the leaders of the
literally
field.
the grandfathers. Like they invented.
Yeah, they were probably the second generation. Probably the first guy would have been, now that I say it, it was a guy out of California, Jack Sheen.
Oh, yes, correct.
And so Jack trained these guys, and then those guys trained me.
But Dallas does the Dallas Rhinoplasty Symposium, all
It's
that.
a hotbed of rhinoplasties.
Right.
So closed approach means you're making incisions inside the nose, and you never expose the cartilages to your view or in a limited fashion. You never see the bone at all.
Right.
And you're doing it all kind of by feel.
Yeah.
Whereas open rhinoplasty was a new thing when I was training and was popularized by those guys. And the difference in incision is only one that those same internal incisions are connected together by an incision through that tissue between the nose. It's called the columella.
Right.
And then you lift the skin.
And so that's the skin between your two nostrils for people that want to know. And you put that kind of at the base of it, and it hides and you never really even see it.
It heals beautifully, and that part of your nose is really looking down. And even if you're dancing on a table and looking up at it, you can't see it because it heals so well.
Right.
So then you lift the skin off the cartilage, which is the wiggly part of your nose, and the bone, which is the solid fixed part, and you can see what you're doing. And guess what? It's a lot easier to do a precision rhinoplasty when you're looking at the tissues and feeling them versus just feeling them.
Right.
So that's open versus closed. And I would bet 80 to 90% of today's modern rhinoplasties are done open. It takes a little longer to open it. It takes a little longer to close it, but insignificant compared to the advantages of reproducibility, accuracy in the surgery.
And then let's talk about kind of three kind of components that I can think of as far as rhinoplasties go, surgical rhinoplasties. One is that person has just got the hump, right? The big dorsal hump is what we talk about. But when you look at your profile, it's not that ski slope, that kind of gentle looking nose. It's just, you got kind of, we used to call them Roman or Greek noses, you know what I mean? But it can be in any culture or anything like that. But talk to us about kind of the approach for that. Why does somebody have that hump, and how do you address that concern for somebody?
Okay, so, a dorsal convexity is a more masculizing trait. And so some of my friends have that, they're males, and I'll say to my wife, boy, I'd sure like to get a hold of that nose. And they'll go, oh, no, they like that.
So sidebar, one time my wife and I were going out to California, and we were like walking onto the plane, and Joe Manganiello, or whatever his name is, he's an actor who was married to Sofia Vergara. I think they filed for divorce, but he was there in first class, and I just happened to stop right by him, and I was like, you know what, I'm going to say something to him. Like people probably shy away from him. He needs to know that he's just a regular guy. So I turned to him, said something to him, and we had an exchange, and I was, that guy's beautiful. I mean, he's like the best looking man I've ever seen in person. I just looked at my wife and I just felt inferior. It's like, I totally, if you go for this guy, I totally get it. But he has one of those noses.
Does he?
And you would think that like, oh man, looking on the outside, or certainly looking as someone who has a beautiful nose like you do, you would think, oh man, I could straighten this out and it could be beautiful, but you really change him. And for men, I think they can get away with that more, but for women, you're probably right. It's a masculinizing feature.
You want a feminizing. So when men come in to do it, they really only want a straight nose. They don't want that concavity. Women can have a straight nose from the bump because that's sort of unisexual, whatever, can go both ways. Yeah. But a feminizing nose is a concave nose, and which is what many women want.
That kind of ski
And
slope with the kind of tip turn.
yeah, and
yeah.
it's you see some with a big ski slope, which we don't tend to do,
Right,
because
right.
if you think you want that and then you find out you don't want it, it's really hard to fix.
It's not natural.
And that's where computer imaging has been very helpful, because you can take a profile view, and the computer imaging very effective at showing you more and more and more concavity.
Yeah, I love that. I see, now that we share an office.
Sharing,
Because
we're rooming.
We've gotten
Too many doctors.
We've gotten too many people here, which is a great problem to have, right? I'd rather have not enough real estate than too much. So now that we share an office, when you bring patient in, it's great. Like, you literally show them the profiles and you say, you want A, B, or C. Yeah. This is where you're starting from. And what degree of that do you think is beautiful? And none of them are crazy, because we see some, I think what we'll talk about in a second is the Hollywood rhinoplasties. Like, what in the world? Where did it go wrong? Why is this happening? How can it happen? There's no way anyone thinks it's attractive, but somehow it does happen. It's just like facelifts. People see a botched one or a terrible one, or somebody like that, and it kind of ruins the game for all of us. You know what I mean?
It makes it an uphill battle to let people feel good about a simple operation that works.
Right. Right.
And it doesn't have funny results. Now, you and I have talked a lot of times about rhinoplasty is the most difficult thing we do.
Yeah.
But that's why you practice and practice and practice and get good at it. And there are distinct moves or techniques to, we're going to talk about making that bump go away. Once you expose the cartilage in the bone, you separate the right from the left, and that leaves a center component called the septum, and that's what's too big, and it's making that dorsal bump.
Right.
You literally sequentially shave it down till you get the shape you want, and then you put the right and left sides back together again. And
you can do work from there. Like, if they've got the dorsal hump, but they also need their nasal tip to be defined a little bit better, you can do all that. Well, what about functional versus cosmetic rhinoplasties? What's the difference if people hear that? Like, and can you do them both at the same time? What if somebody says, my nose broke when I was 10 years old and I can't breathe out of my right side. So, but I also just kind of don't like this hump, or I think my nostrils are too wide, or how can you address those things at the same time, and can you? Is it safe to?
It is safe to. It is frequently done, because when you're doing the surgery, you're kind of disassembling the nose so you can go look at that trauma.
You're literally deconstructing, and then trying to set a foundation to then construct over what's...
So if the trauma has caused a deviated septum, so the septum's pushed into one side of the airway, it's like having a straw that you can't breathe through because part of the straw is collapsed.
Right.
So you open that straw back up by moving the septum to the midline. Sometimes those cartilages that are on the top of the nose, they collapse when you take a big breath. That's called an internal valve problem. Right. Sometimes the nostrils collapse because they don't have enough support, and you need to give that more support so they don't collapse when you take a big breath.
Yeah.
Those are the most, the most common thing is the turbinates, which warm, filter, and humidify the air. Yeah. As it prepares it for the lungs as it's inhaled. Sometimes those are
big.
They're instead of being the size of your little finger, they're the size of 3 of your fingers, and then you need to remove those or just make them smaller.
Okay.
And you can do all of those at the same time you do cosmetic procedures.
And so I know people are going to ask you, like, do you break my nose?
So I would say we make osteotomies, or we make cuts in the bone. So if you look at the nose from the bottom, sort of the worm's eye view, it looks like a triangle. And if that triangle's too tall, we take the top off the triangle, but that sort of leaves an opening. So you need to move the bases of the triangle closer together to close that roof.
Gotcha.
And that's where we make cuts in the bone, breaks in the bone, to close that open roof deformity, and it's done on many, but not all, dorsal hump removal.
Right, but you're right. Like, if you're shaving off someone's dorsum, and you can think of it like an A-frame house, if the top of the A-frame is just too tall, right? It goes up way too tall, and we need to kind of de-slant that roof and bring the height of it down. If you just came straight across the top, you'd be able to look inside from the sky. You'd be able to look in there, and you certainly don't want that. And so you just kind of got to make little fractures along the roof line at its base, and then it can fold in and deproject and close back over. And it's funny because it actually is called an open roof deformity, which is kind of neat. Okay, I'm going to ask you a question that is, and then I'm going to ask... And then I'm going to ask Linda to talk about liquid rhinoplasties. But this is one of the, you do a lot of male rhinoplasties. And when we're in training, when we're young in our practice, which you are not so young, you are
Well
seasoned.
put.
You are seasoned.
Oh,
Isn't he
that's
kind?
gentle.
The male rhinoplasty is like, it's a real hot topic because a lot of times, I forget what the acronym is that you talk about,
yeah.
but it's often
Simon?
Yeah, that is what it is, and I forget kind of
What
what
the acronym is?
Yeah, but it's all about like how they have unrealistic expectations and how there's a lot of things for male rhinoplasties. Like what's the most common male rhinoplasty request?
Probably dorsal
Yeah.
reduction.
Yeah.
The hump is just too big.
Yep.
Sometimes they're just too broad. But those would be the biggies. And airway problems, soccer injuries, basketball injuries, that kind of stuff.
And talk about briefly, before I get to Linda, briefly about the nose and the chin and how those
Good
can
question.
come into play together. Sometimes somebody thinks their nose is too big and really it's that their chin's too small or those types of things.
The
like
facial disharmonies.
Right.
So it turns out that there's a guy named Farkas who measured faces on beautiful people. The facial proportions in beautiful people tend to be the golden rule, where you have the lower face is equal to the mid face, the lip to chin distance is 2/3 of that, and the length of the nose is 2/3 of the mid face.
And literally, we have textbooks that have diagrams of
Yes,
this. I mean,
exactly.
it's amazing.
And then the tip projection is 2/3 of the nasal length, which is 2/3 of the mid-face projection, which is equal to the lower face projection. And so when we take these pictures that we morph on the computer, we also look at those numbers to confirm what the clinical impression is. We verify with those numbers.
And so do you go into surgery with like lengths, numbers,
Yes.
all that kind of stuff?
Yes,
And that's
the
what you
chin
use.
falls into that, where you can see that if you draw a line from halfway down the length of the nose through the upper lip, the chin on a male ought to touch that line, and on a woman ought to be within 2 millimeters of that
Okay.
line. And if it's not, then the computer can show the patient a chin implant put
Okay.
in place.
Yep.
And sometimes that's called like retrogenia, but sometimes there's a thing called microgenia where the chin is just too small and it may be too far back, and then they need a chin implant that drops the chin and moves it forward or enlarges it. And sometimes those are more than we do, and we
Right.
refer them to oral surgery
Sure.
to do
Yeah.
fancier technique.
Yeah, and they can actually, that's when you hear people that talk about, I had my jaw broken so that I could advance my chin
Z.
and things like that. Right. So that certainly happens. Okay, Linda, I see all the time that comes across, I don't look at social media that much, but what I do notice sometimes is people talking on both sides of the aisle on liquid rhinoplasties. And what we mean by that is non-surgical. We mean using filler to help mask, disguise any camouflage. That's probably even a better term. Camouflage any, angles or bumps or any of that stuff that they don't like with their nose. And there's some people who are staunchly against it. Not safe, don't do it. And there's people who are just kind of cavalier, willy-nilly. Where do you stand on it now? How has your stance on it evolved? What do you think about using filler as a means for rhinoplasty?
I have felt both ways, because up until probably 5 or 6 years ago, I did perform liquid rhinoplasties and got beautiful results, because you really can camouflage deformities. And then I went to my very first cadaver course, and my eyes were greatly opened at the potential risk of injecting in that area. And so I took that off of my plate at that time. And the other reason is that because of you guys, because we do have Dr. Graper, who is seasoned. See, I'm seasoned too. We're good at that.
Yeah, you're salt and pepper.
There you go.
A little bit cayenne.
A little cayenne. But because, we do have our OR here and we do have Dr. Graper that I can refer patients to have a surgical rhinoplasty. I just prefer not to do the liquid rhinoplasty. Our practice, because of the risk.
But tell them the risk. Tell them what can happen if you walk into some place that really maybe doesn't know what they're talking about, and they see your nose and they say, "Oh yeah, you got a hump. Well, I can put some filler on either side of that hump and flatten it out," because you see some pretty dramatic results.
Oh, it's beautiful results. It's right.
So how can it go wrong?
Just like with any other area of the face, anytime we do fillers, there's a potential risk of intravascular injection, and that means injecting the product into a vessel. If that were to happen and it occluded a major vessel, then there's a potential of a stroke. There's a potential of blindness. There's a potential of necrosis, which is dead skin. And, knock on wood, we don't have those problems, but we could. We could. We know anatomy, but everyone's anatomy is different. There are things that we do as we inject every area to assure that we're not intravascular. We aspirate to make sure we don't have flashback, to make sure we don't see blood. And yet there is still the potential of that. The areas that we do inject filler that are FDA approved, there's just less risk of those important vessels that feed into the ophthalmic artery. And so that's the risk, is the potential risk. But, just know that we take all fillers very seriously, even injecting lips, even injecting cheeks, even injecting temples and folds. Those all carry a slight risk of an intravascular injection. We do have a safety net. We've got Hylenex, which is a product that will dissolve the filler if we were to get into a problem like that. But, we're all about safe.
It's best to just not have
reliable.
the problem.
Yeah, it's best.
It's always best to not have the problem.
So that's my stance on it. Now, I'm that staunch person who is not going to do liquid rhinoplasty. And I'm very confident to send that patient to Dr. Graper. Sure. And I'll say this, having had a rhinoplasty myself years ago, probably almost 40 years ago, I love the results of that. I had my daddy's nose. It was good on my daddy.
Exactly.
But I had nose all over my face. And so that was not so good. And, you're talking about open rhinoplasties. You cannot see the incisions at all. So it's a very safe and beautiful procedure. And I feel more confident in sending patients to Dr. Graper to have a surgical rhinoplasty as opposed to me, injecting with filler.
And taking the risk, which is not high, but blindness is a severe problem if you get it. And so any risk of blindness is probably too much. And you don't have a risk of blindness injecting the lips or the cheeks or those areas, but you do on the nose. Yeah. And since there's a permanent, and even, let's say you do an injection on the nose and it looks lovely and you didn't get any of those problems, you still got to do it again next year, or certainly no less frequently than every 2 years. So Eventually you do it for 10 years or 15 years, your odds of getting that problem go way up.
Yeah.
And since there's a safe, surgical, effective solution, without that, surgery makes a lot of sense in that scenario. Now, let me also say, if you have a minor thing, that the cost of surgery, the risk of surgery may be more than a small little dollop of filler that corrects the problem, then that gets to be a gray area where in those cases it may make sense to do it that way. But for a standard rhinoplasty that there's a good surgical solution that has none of those risks, I think Linda's effectively describe why it's not the best option.
And so some of the filler that you use for those little dollop cases that are good to help, is that patients that have, kind of nasal tip issues?
For me, it had been more dorsal issues where you get a fractured nose and it's got a little depression.
Gotcha.
That's the best. And you just fill that depression up and it takes 15 seconds and they walk out the door looking great. And maybe a year later they come back, or maybe 2 years later. I don't know if your preferred filler was Voluma or was it?
So for that area and for scars, probably Velour or Volbella, and they're FDA approved for 12 to 18 months.
Okay. Not a bad option.
Yeah.
And, when you make those cuts in the bone, sometimes there can be a little depression there, which is a nice way to do that rather than a much bigger surgery. And the risk is there, but if done, with Linda's good technique, I think it's not high. But if you're trying to put a lot more filler in the nose every year to do that same liquid rhinoplasty, the odds are not as good. The risks go up.
Well, I'm going to tell kind of another funny story because that's all I'm really good for this interview. But I want you to think about the overdone nose and how people see that.
The Michael Jackson nose?
Well, I'm going to talk about him. Funny story. So I'm going to swing back to you, but I want you to kind of say, why does that patient look like their nose is completely pinched and they look like they should live in Whoville? Like it's just not normal. And what the undertaking is to fix some of those things. Because a lot of times cosmetically, when you see that nose done from a cosmetic purpose, they have taken all the structure out of the nose and you have to rebuild it from the ground floor up with rib cartilage, with behind the ear cartilage, with temporoparietal fascial there's some crazy maneuvers. So
I've done those.
I know.
They're hard.
And I want you to talk about how to make sure our patients don't get that overdone nose. But my story is I started plastic surgery training at Emory in 2019. And in my general surgery residency, 2009.
Wait, he's more seasoned than that, right?
Yes, he is.
I feel so youthful from all the cold plunging I do. That's what it is. So
it's the Botox.
There were three residents in my class of 5 that matched in plastic surgery, which is pretty great. We were actually the only general surgery program in the country that matched 3. One went to Miami, one went to UCLA, and I went to Emory. And the guy that was at UCLA, this is, we started late June, early July, something like that is where we started. He had started at LA County Hospital. That was the first hospital that he was assigned to. And he says, I'm at Emory. I think I'm on like my craniofacial something, but I'm in the lounge at that point. He's like, Garrett, you're not going to believe this. So I'm at LA County Hospital on my rotation, and they just brought Michael Jackson in, and he's dead.
Whoa.
Like, he's like, I think I'm going to go try and steal his nose and sell it on eBay. I was like, don't do that. That's a bad idea. So he didn't do it, and nobody went to jail. But he was right. Michael Jackson had so many nose jobs that he lost his nose and wore a prosthetic nose.
Oh, I didn't know that.
Oh, yes.
Well, I would have thought it'd been a better looking prosthesis than that.
That boy was glued on.
Oh, my God.
Oh, that bad boy was glued on. That's why he was going to go steal it.
Oh, I was thinking that this is kind of macabre that he's going to cut his nose off, but if he just had to unzip it.
No, yeah, just
Seriously?
Oh yeah, just unseal it. Yeah. Wow. So when you see people with just these crazy little pinch nose and they can't breathe and all these kind of things, obviously, like what we talked with Linda, best to just never have the problem. But when somebody comes to you and says, oh my gosh, I went to Miami and I had my rhinoplasty, or I went to Turkey, or I went wherever people go for like medical tourism, which is what they do now. And they've just got this nose and they say it's non-functional. I can't breathe out of it. And it looks too pinched. It looks too weird. What's the undertaking like? Briefly, like you don't have to go into crazy.
That's when you get into those rib cartilage grafts and ear cartilage grafts you kind of recreate the defect and separate right from left and put new structural support in and hope you get enough skin envelope to cover it all and then try to...
It's a real problem.
It's a real problem.
It's a real problem. So what would somebody expect after rhinoplasty? What's their kind of first week look like? What's their first 48 hours looks like? And then when is all the swelling gone and this is your nose? Congratulations.
They get a splint on the inside of their nose to stabilize those bones. They get a splint on the outside of the nose to stabilize those bones. Both those splints reduce the swelling and bruising. They wear those for a week. The stitches are only the external stitches in the columella, but the tissue between the nares, the nostrils, that comes out at a week as well. The internal stitches are dissolvable. So at a week, they've got both splints out. In between then, they keep their head up. They stay away from salty foods. They're not exercising. We don't want to increase the venous blood pressure or the arterial blood pressure. And after that, when we pull the splints out, they breathe great because that airway's been stabilized. And a lot of times the swelling will come back in after those splints go away. So for a couple weeks after it, they can be a little congested. The swelling goes away from the top down. So the swelling at 6 weeks is pretty much gone from the top of the nose near the eyebrows. But the swelling on the tip of the nose, especially if you've done changing the tip shape, that can take a year or a year and a half to really show up, and people think, oh, it's 6 months. Okay, that's what I got. Nope.
But they're not swollen like you bopped them in the nose. It's just almost a molecular level swelling. There's some swelling, but it's
Early
not.
on, it's swelling.
Right, but nobody for a year wants to walk around with like, whoa, what happened
I'd say
there?
what
Did you get stung by a bee?
I should have
no.
mentioned that about 80% of the swelling is gone at 6 weeks, but that last 20% on the tip is where all the definition comes out.
And it's
But
just
I
like a
feel
scar
like
maturation too.
It seems like, and again, from my own personal experience, I feel like even 2 weeks out, even with still some swelling, at 2 weeks out, it looks better than it did before surgery because, the hump's gone, the definition that
absolutely.
you've given
We
is
did
there.
a young man 8 days ago, and we saw him yesterday for the first time take his splints off. His bump was gone. Well, we took 4 millimeters of his septum out.
Yeah.
And then put the roof back on and did all those things.
And that's a
talked about.
1/6 of an inch to the people listening. Like, it doesn't sound like a lot, but that's a lot.
Makes a big difference.
That's right. All right. Well, we are going to wrap
look
up.
great.
I want to thank Dr. Bob Graper, obviously, and Linda Owens for all of their
Linda.
insight in this. They did a great job. If you have questions or topics you want us to cover, guess what? Visit ghsurgery.com. Click on the Doc Dudes from the homepage. There's a link to click that you can submit your questions and ideas. You can also listen to all the Doc Dude episodes on our website, as well as Apple, Spotify, YouTube, anywhere you listen to your favorite podcast. Follow us on Instagram and Facebook to find out when new episodes are dropping and other information about our practice. You can sit in bed, this is a new kids term, you can sit in bed and rot and just listen to all our podcasts. I just sounded hip right there.
That's cool.
Using new terms, right. That's
There you
exactly
go.
right.
You're
All right,
cool.
well, thank you very much. This is Garrett Harper signing out for the Doc Dudes, and we will see you next time.